Good morning and welcome to another ECW podcast. I'm your host, Brian Saul, and we are here in DeQueen, Arkansas, speaking with Dr. Randy Walker and Angie Walker. Today's topic is going to be Comprehensive Primary Care Initiative, CPCI. And first of all, thank you so much for being with us today. We really appreciate your time. Before we get started with the questions, can you tell us a little bit about your practice to begin with? What sort of population do you see? You're a family practice, and you've got some allergy work going on there as well. But just give us a general sense about what your practice is like.
Really, we see from birth to death, I guess. And we set fractures and EKGs and X-rays, and just really we try to take care of everything that comes through the door.
Full suite of
full service.
Yeah, that's fantastic.
Yeah.
I would say we probably have an active patient population with a look back of about 1 to 2 years, probably about 3,500 to 4,000 active patients.
That's fantastic. So let's start talking about CPCI a little bit. How did you first learn about the initiative?
We work pretty closely with AFMC, which is the Arkansas Foundation for Medical Care, and my liaison or my rep, Kim Miller, came into the office one day and said, hey, there's a really great program that's coming out, and we think you should apply for it. We're very proactive in programs that are coming down the pike, especially those that are pilot that people are studying and watching. Because we want to know, we want to be ahead of any changes that are coming, and so we had just finished up a program with them, and she said, "You guys, you would roll right into it. This would be perfect for you." And so
now, just actually, I should take a step back and just if we can give a brief description of what CPCI is. CPCI is a program that was put in place by the Center for Medicare and Medicaid Innovation in 2012. It's a 4-year program. It'll be ending at the end of this year, 2016, and will be replaced by CPC Plus. The initiative will to pay selected caregivers across a certain number of regions of the United States as sort of a pilot program, and then see how well the program is working before launching into CPC Plus. So that's just a very, very brief overview of it, but I think we'll be able to get a little more in depth as we talk about it this morning. So when did you actually get involved with CPC?
we were in it from the get-go, and so we had just finished up the Arkansas Chronic Illness Collaborative, which was a lot of the same things that CPCI was coming into. And so we had just finished that collaborative and found out about CPCI, and so applied for it and of course got in it. And so we started from the get-go.
Can you tell me a little about the application process? What was that like?
It was a very easy process. I mean, you pretty much, they needed to know your patient demographics. So you have to be able to identify your active patient population, race, demographics, ethnicity, things of that nature.
Okay. There's also a technology component to it as well.
Yes, especially in CPC Plus, if you're moving into Track 2, you very much have to have a very active relationship with your EMR HIT vendor.
Now, CMS offers other, for lack of a better term, calling them incentive programs, such as chronic care management, where if the patient is seen for 20 minutes outside of the office can bill for $42 a month. But there are some caveats that go along with that. Patient needs to sign a consent form and also has to pay an $8 per month copay. Does CPCI have any of those sorts of requirements? Is there consent forms that need to be signed or additional payments made?
No, and for the most part, when you do CPCI, you can't do the chronic care management part of it. With CPCI, we are required to make sure that we have notices in the office that say we are participating in this project, and if you wish not to participate in it, your data not to be discussed and what have you, you can ask to be removed.
Okay, so you can opt out of the program if you choose. Okay, but there's no opt-in, so to speak.
No,
you're automatically,
and you have to make an effort to opt out.
Now, one of the unique things about CPCI is its payment model. So it provides, if I understand this correctly, and please correct me if I'm wrong, I understand that it still will allow you to bill fee for service, but then on top of that, there is a monthly per patient per month fee that you're going to receive. And then there's also some shared savings. Have you been involved with all of those three areas?
So yes, in CPCI, you do, it's a risk management fee based on the patient's risk level that you get to help with those expenditures. Arkansas did not receive shared savings for this
Oh, you
previous
didn't?
year.
Okay.
No, it did not. And so it is a little bit of an alternative payment model there.
Let's talk a little bit. Let's go dive a little deeper and talk a little bit about the 5 primary care functions, which are the access and continuity, planned care for chronic conditions and preventive care, risk stratified care management, patients and caregiver engagement, and coordination of care across the medical neighborhood. Can we go through each one, and can you talk about any struggles that you've had, or even better than struggles would be how you actually accomplish meeting these guidelines? So access and continuity.
So that one I think was a pretty easy one for us. Like I said in the beginning, we did not have ECW as our vendor for the first year, and quickly realized that we had to do something different. We wanted something that had better patient engagement, because we needed that. And so when we moved into ECW, we were able to do, of course, your access via the patient portal. So you have huge access and availability to things on your portal. As far as the office was concerned, we basically at that point had hired a nurse practitioner, and so we looked at a staggered schedule. Initially we just staggered lunches, still Monday through Friday, took all major holidays and what have you, and as we moved into that second year of the program, it was like, okay, if we're going to give access to patient, we're going to have to really look at these things. And so we went into the nurse practitioner decided that she would like to come in at 7 o'clock in the morning, working until 4 o'clock, and then Dr. Walker decided he would like to come in to 8:30 and go to 5:30. So we got, not only did we get 2 extra hours in the morning, an extra 30 minutes at the end of the day, and we also had the staggered lunches, but we also had both of them doing urgent access appointments. So for each of them, they had an hour at every day that could not be booked until that day, for those patients that called at that time. And then of course as any clinic does, we have standard times that are you overbook for no-show. And so we had the same thing going on.
And then as far as the continuity, we got ECW. I said, hey, this thing looks like it was written by doctors. And
It was.
Come to find out it was. But it really allows, as far as the continuity part of that picture goes, it really allows one provider to communicate with another provider very efficiently.
Right.
So transition of care is that much easier.
There's a big part of the medical record is just redundancy, and the ECW allows for that. But then there's certain parts of the medical record that are very important for one provider to be able to efficiently transmit to the next provider, and it does that well.
Well, I guess then the follow-up question to that would be, have you added any staff since you got into the program to help accommodate CPCI?
We have retrained staff.
I would say we didn't really do anything, I don't think, as to get ready for CPCI. It just seemed like CPCI was a direction we wanted to go in.
Well, we had already been. We
Yeah.
were already in that direction because of the Arkansas for the ACIC, where we were managing chronic disease, where you were actually looking at chronic disease as population health. And so what happened was we took the staff that we had at that moment and said, okay, your job as you knew it is gone. As a nurse, you are no longer going to room a patient, take vitals, and pass it on to the physician. You are now going to be actively involved in this care. And so we took the staff that we had at that moment and retrained them to meet the needs or how we wanted to manage that patient.
You mentioned care planning, and that's the next topic on this list is planned care for coordination of chronic conditions and preventive care. How did you go about doing that?
So we're very big on team-based care. Everyone must practice at the top of their licensure. Dr. Walker has standing orders so that when it starts at the front desk, when the front desk checks that patient in, she can see, hey, this is a high-risk patient. And so it just moves on to the rest of the staff. The nurse knows when she pulls the patient back, oh, I'm sorry, you're a diabetic, or this is a diabetic patient. I'm going to look over here in your CDSS alerts. I'm going to see if you've had your foot exam, your eye exam, your microalbumin. They're actively involved in that planned care. And our planned care starts with, I think we identify the top 10 diseases or diagnoses in the clinic, and then created standing orders for that. So it empowered our staff to start helping with that planned care, because one person can't do that.
That's great. That's a wonderful way of approaching it. But so, continuing on with that thought of planned care, do you use care plans?
We do. There is a wonderful initial care plan that comes with our module. That's a very extensive care plan, and we use that for our high-risk patients. We then went on to create what we call our shorty care plans for our medium and low-risk patients that are not necessarily disease or diagnosis driven, but it can just be a health part of it. You come in and we're looking at, you need to increase your exercise, your weight, or decrease your weight and stuff like that. So we've created several to kind of match our practice demographics.
Risk stratification. You mentioned you're identifying risk up front. Are you, I guess the management part of that is really the question, risk stratification management. How do you go about handling that?
So, you want to answer or you want me to answer?
Well, you can answer. Go ahead.
So Dr. Walker created a risk stratification tool before we started CPCI. And that tool is based on disease, where you're at in your disease, and also your utilization of services. And so when we came into ECW, we were able to create that tool into the note so that when the nurses pull those patients back, they automatically risk stratify them every time.
Do you assign them scores, risk scores?
Yes.
Yes.
Yeah.
Yes, ours is very low, medium, and high, but it's based on a numerical count as far as how they're answering questions. And of course, once you pop into that high risk, there's then other steps that we're going to do within the practice to start helping look at those patients.
Okay. Patient engagement, patient and caregiver
Caregiver engagement.
engagement.
So, you want me to answer?
Yeah.
Okay. So this was like my baby, I think. I love this one. This was the reason why we left our old EMRs, because we could not reach out and touch those patients without them being in the office. With the old one, the only time we ever saw them was when they came in. With ECW, we were able to really ramp up patient engagement via the portal, via campaigns, they're able to email the nurse, they're able to email the front desk. It was just my favorite. It was the whole goal of everything that we were doing. And we were a little worried at first, because when we popped in, we were stage 2, year 2. So we were a mandatory 90 days. And so we did, I guess, what you guys would call a rip and replace in August. So we had to hit everything come October, November, December. And so this was the one that we were worried about, and we blew it out of the water. I mean, patients just loved it.
That's
I mean, they were very actively engaged in the office and what was going on, and being able to get onto that portal and look at things and ask things, and it was awesome.
It's interesting when we're talking about patient engagement, along with some of the other topics that we've had so far, a lot of them seem to run parallel to meaningful use. So, for example, with your patient engagement, being able to speak electronically with the patient, have the patient speak electronically with you, that meets meaningful use measures as well. So, coordination of care across the medical neighborhood.
ECW has provider-to-provider referrals, so that all of the results from EKGs and CTs and laboratory are sent directly from provider to provider, if you're both users of ECW.
Which helps, because you're not going to have duplicate tests,
Exactly.
et cetera. So that's a very big cost savings
Yes.
piece as well.
I would just say we're very actively involved in our community. So one of the big things that we did is we sit down with home health. We sat down with the hospital. We sat down with different agencies and said, okay, this is how we're going to manage our patient. This is what we expect as far as care goes for our patient, and this is what we expect from you. And we continue those meetings. We have biweekly home health meetings. We meet with DME. We just want to make sure that everybody understands where we're at, where we want to be, and what we want for our patient. And so I think, as far as coordination of care across the medical neighborhood, I think you have to you have to really look at your neighborhood and engage those businesses that are in healthcare as well in that.
Right, making sure that everybody's on the same,
the same
page.
page.
Yeah,
Mhm.
essentially. That's fantastic. And we'll be back in just a minute. Please stand by.
Have you been to an eClinicalWorks Days event? If not, you're in luck. During 2017, the eClinicalWorks Days team will be visiting 62 cities across the country. Each event offers a main classroom agenda, as well as other specialized sessions to provide you with a whole day of learning. And if hands-on is more your learning style, we offer 20-minute one-on-one sessions with specialists from our EMR, billing, and EBO teams. And it's all available at no cost to you. If you're interested in attending one of these events or want to see when we'll be in a city near you, please go to www.eclinicalworks.com/eclinicalworksday. We hope to see you there.
Hi, welcome back. We're here in DeQueen, Arkansas with Dr. Randy Walker and Angie Walker, and we're talking about CPCI. We just finished talking about the five functional areas that CMS was looking at, but there were also an additional 9 milestones that were involved with that. Now, I understand that those changed from year to year, the different components. Is that the case?
There wasn't really that much change. I didn't notice that much change. The milestones to me relatively stayed the same. Your reporting might have changed a little bit as you moved through the years, but the milestones were always the same.
What sort of challenges did the milestones pose for you?
I think the getting patients to participate in their own care, to take responsibility
Yeah,
for their own disease is probably the hardest part,
The hardest.
which is the hardest part in all of
I would
it.
say across the board, that's going to be
Right.
the most difficult.
Because I would say for us, we're used to studying measures and looking at numbers and pulling out fallouts and trying to figure out where there's issues and what we need to work on. So we already had something in place where we were monitoring. And so that just became a normal extension for us as far as we're going to meet this week on milestone 2, or we're going to pull the measures for shared decision making or what have you.
You have that wonderful whiteboard in your office that I find to be just genius, so that at a glance you can tell where you stand with your different CQMs, which is an inspiration for folks that work in the office to make sure that they're doing that correctly. And as you mentioned it seen by patients, so that they know that this is a level of quality care that they're receiving. I think it's a great idea.
It was important to us. At first, we were a little bit nervous about putting ourselves out there because we did put it in a very public area. But we also realized that there's some measures that we simply can't meet without the patient being involved. We can set a goal of 30% of our patients receiving a mammogram or a colonoscopy, but if patients don't participate in that, we're never going to reach that goal. And so it was important for us, for the patients to see that they had a level of responsibility in meeting that goal as well.
Sure. Yeah, sure. Now, reporting on those measures, did you self-report those? Did you self-attest? Mm-hmm. And how difficult was that? I've seen some of the forms, and to me, honestly, it looked kind of convoluted, but tell me if I'm wrong.
I didn't have a problem. I don't feel like we had a problem with it. Of course, I use I have a CPC coordinator that she and I chit-chat once a month on the phone. We pull measures every month. They're put into my dashboard by the 10th. She and I have a standing conference call the Thursday after that. We look at what's going on with those measures, where we need to be working on things, if there's anything that needs to go on. And so when we get to that reporting period, we're actually very familiar with what's going on. We've already with CPCI, you report on a quarterly basis, so you know early on if you're having issues and you can correct those. And so when we get to that quarter, it's good data. We know what we're looking at. We know that it's good, and so it's just a matter of taking that information from the dashboard and putting into the reporting module.
That's a very good segue into my next question, which is, what sort of assistance did CMS offer you when you got involved with the program?
So what they have is I'm not sure what you would call it. It's transfer med. So TransferMed comes in and they do a lot of monthly webinars on just different topics that we're looking at, whether it be medication management or shared decision making. There's all kinds of little different groups that meet, and there's probably at least 2 or 3 webinars a week. We also have what's called CPC Connect, where we can actually go out and it's almost like a Facebook platform, and we're able to talk with other clinics and figure out things that are going on and what have you. We also have our own TransferMed rep, so if that anytime we have issues, they will come on site to help us move through any obstacles that we might have, or if we have reporting questions or what have you, we can reach out to them.
That's great. So they really did provide quite a deal of assistance in doing this program. That's fantastic. So you mentioned earlier on that you were using another EMR when you began the program, and then moved to ECW. My original question was going to be what changed in your flow if you were using ECW from the full time of using the program. But really what I want to know now is, were there any particular functionalities within eClinicalWorks that you found to be particularly helpful in meeting the measures and meeting the core functions?
Well, from just a practical day-to-day point of view, I love the way ECW has variable portions and constant portions. I'm really big on using the yellow stickies, the pink stickies, and then the variable portions of the care plans. It allows the nurses, the care managers, the other providers in the clinic to communicate with each other quickly.
Right across the spectrum.
Right.
Yeah, and it's right there when you look at the notes.
Yeah,
so you don't have to search for it. It's just there right in front of you. So.
And I think I really like the ability to track things. I love data. And so being able to map things and look at different things, 1 month we did a study on PT and INR, and we were trying to figure out if this piece of education helped better, or this one, over another one. And so the ability for you guys to create an area for me to map and be able to track numerators and denominators and know whether something we're doing in the office is making a difference is just awesome to me. Yeah. I can actually really know versus, I'm going to ask the nurses and they're going to say, oh yeah, it's good. Oh yeah, it's good. Everything's good. But when you actually can run that measure or run that question and you have data right in front of you, there's no arguing with that.
Yeah, that's...
So, the
old saying, you can't manage what you can't measure.
That's right.
And that's absolutely the case, and that's why I'm glad you have this.
Well, and my thing is, it allows us to measure what matters.
Yeah.
So.
Overall, your experience with the program has been...
Love it.
Yeah, we love it.
Love it.
That's great. Well, thank you guys so much for talking with us today. We really appreciate your time and the energy you put into the interview. It was really a wonderful experience talking to you. So again, thank you. So meet us again next time for more ECW podcasts. You can find them on YouTube, iTunes, and myclinicalworks.com. Thanks for joining us today, and we look forward to seeing you again.
This broadcast and its contents are the sole property of eClinicalWorks and are protected by federal law and international treaties. You are strictly prohibited from making a copy of, modification of, or form of rebroadcasting or re-encoding this broadcast without prior written permission from eClinicalWorks Public Relations, except as may be permitted by law. This broadcast is provided for informational purposes only. It is intended as a personal, non-commercial use. Product specifications are subject to change without notice. Please contact eClinicalWorks Public Relations with any questions. eClinicalWorks V10 EHR is ONC HIT 2014 edition certified as a complete EHR. eClinicalWorks V10 CC 2014 955447-1.